I'm Karen Smith. I'm the clinical ethicist for the Henry Ford Health System, and I'm very happy to have yet again another fabulous panel for you today. I'll introduce our speakers and then they will come up as we go along. I ask that you hold your questions to the end. We've tried to allow about 20 minutes for questions, so I hope that you'll be thinking of them as we go along. We have an expert panel ready to address them at the end. Our topic today is ethics, end of life, and opioids. And you can imagine just from that title all the way that things can get confused and how difficult it is to decide in these situations what really is the right thing to do. Ethics comes part of these conversations because oftentimes there's more than one good or bad choice, yet we're forced to make a decision. Not only that, the consequences of those decisions can be very difficult to accept. Oftentimes, they are truly life and death decisions. We come to these end-of-life decisions and touch points, all of us bringing with us our own histories, our life experiences, our emotions, all of our own personal baggage that's made up of our personal values and beliefs. And those are very complex. Oftentimes, we're not even always consciously aware of what our values are related to those things that involve end of life, related to those things that involve taking drugs, right? Narcotics, things that change your consciousness and relieve pain. So all of these emotions come up at the end of life when we're working with these decisions involving loss, family conflict sometimes, impairment, and pain. So that's kind of the milieu that we're going to be talking about today. Why is ethics and opioids in the end of life an ethical issue? Well, if you think about our larger principles, most of them come into play with this topic. Beneficence certainly is the easy one, right? Our goal is to relieve a patient's pain, and that is an objective good. That's what we're trying to do. Non-maleficence, though, is also involved because pain is not only physical, it may be emotional and spiritual, and we're trying to relieve those harms in our end-of-life care that we are able to relieve, right? So multifaceted ways of relieving harm or reducing pain, those also are goods. And then autonomy. Patients have the right to self-govern. They must be informed of their options for pain control. And at times, patients may lose their autonomy at the end of life, forcing those decisions to go to their surrogates or to their prior expressed wishes through an advance directive, right? So autonomy is something that patients do not always have, but they may have expressed their autonomous wishes prior. The last ethical concept that we're going to talk about just a little bit that's often involved, especially with opioids in the end of life, is the principle of double effect. And the principle of double effect, I'm sure you studied it long ago when you had that semester on ethics, has four things that have to happen in order for the principle of double effect to hold. The first one is that the treatment must be the only means to meet the end desired. And so when we're talking about pain control, that's the relief of pain. So opioids are used to relieve the pain. That one's pretty easy. Second, the physician must intend only the good effect, in this case the relief of suffering, where the bad effect would be a potential for loss of consciousness or increase in respiratory distress, things that might hasten death. So we have double effects, meaning that there is a good effect, relief of pain, and a bad effect, the cessation of respirations earlier or elimination of sentience and being able to participate with their loved ones. Thirdly, though, the good effect must, in moral analysis, outweigh any unintended bad effect. So the good effect has to be greater than the bad effect. We always say in ethics we're weighing and balancing, so we have to make sure that the good effect is weightier than the bad effect. And although the bad effects may happen, it's oftentimes unlikely. Finally, the bad effect, which would be greater sedation or possible earlier death, should not be the means to the good effect, right? So we can't utilize dying to get the relief of pain. That's not what we're hoping for. We're hoping to use the opioids to relieve the pain. If we were to allow the bad effect of complete sedation or an earlier death to be the sole means to the good effect of relief of pain, so we can't do that. So, going through this, looking at this complex interaction between opioids, end of life, and ethics, we have a case example that will be talked about with some of our experts as we go on. This is a 60-year-old man with a history of rectal cancer with metastatic disease to the bones, liver, and lungs who had been on the oncology service for a number of years, receiving multiple rounds of chemotherapy. He was followed by palliative chemotherapy and radiation. He failed multiple attempts at pain control measures by oral and IV methods. He had multiple hospitalizations for inadequate pain control and constipation. Eventually, though, his pain was well controlled by transition to a fentanyl PCA. The patient refused inpatient and home hospice care multiple times. He believed that hospice was a place where patients went to die. He knew he had end-stage disease, and he was agreeable to having a home health agency nurse visit him 3 times a week to change his PCA pump and assist with other things that he might need as he went along. This worked well for about 3 months. The treatment plan was put into place. Then the patient presented to the ER with uncontrolled pain after his fentanyl PCA was damaged. He stated that he was at home cooking steaks when he accidentally cut his fentanyl infusion bag with a cleaver, resulting in the infused medication draining into his sink. So, not surprisingly, this story was viewed as highly suspicious, right? Multiple things. One being that the patient really lacked the strength to stand at a stovetop and cook, just to start that one off. And for several months, he had been eating only very, very soft foods. And lastly, the type of the cut made to the bag was deemed as suspicious. The patient's son was present for this last ER hospital visit, although the patient had never mentioned his son on any of his prior admissions. At previous clinical encounters, the patient had always requested that his girlfriend of over 30 years help with his medical decision-making and identified her as his healthcare power of attorney, yet she wasn't present at this last ER presentation. The patient's son was very vocal during the admission. He defended his father's story about the cleaver and the steak, and he also tried to become involved in the decision-making process regarding further treatment goals, despite never having been involved with his care in the past. So, that's something, a story, a clinical case that kind of brings in a lot of the issues we're talking about, pain control, end of life, and ethics. So, we'll bring up our first speaker, which is Dr. John Bolak. He is the Medical Director of Geriatrics and Palliative Care at Macomb. Thank you for making the trip over. Following Dr. Bolak's presentation, we will have Dr. Michael Ryan from our psychology service talking about some of the psychological aspects that are involved in these complex situations. And then lastly, Dr. Jonathan Rose from our palliative care service here at Henry Ford will talk about these issues as well. So welcome to all of them, and I turn it to my esteemed colleagues.
Well, thanks everybody for having me today. I see some familiar faces, and I know there's several familiar faces that are listening in the audience. So thanks to have us today. So, talking about some of those that case that was just reviewed, obviously it paints the picture of some of the landscape that we're in. We have a lot of changes in the landscape of prescribing in regards to opioids. And when it comes to it, there's been a lot of legislation developments. There's limitations on the number of days that you can prescribe medications, controlled substances for, limits to the amount of days that you can provide those things. You have to make sure that you're counseling your patients, documenting those counseling events, making sure that you're establishing a contract to make sure that those patients, their family that are involved, the guardian, the advocate, they're involved in that process. And for those that don't know, there was recent legislation that kind of was put into law. It was a House Bill 5152 and 5153, essentially mandating for patients that would require one, a non-opioid advance directive. So this is a voluntary form for patients that really don't want to have to be exposed to opioids, or maybe their caregivers or their surrogates don't want them to be exposed to opioids. It essentially asks that providers not provide opioids during the care setting. That being said, it's kind of a dynamic document in itself, a dynamic advance directive, just like advance directives are kind of a framework. It's not necessarily going to be always the case in regards to care. So when you have an advance directive, you usually have a centrally appointed person that helps to navigate decisions based on your values. In a way, this is kind of a document that suggests how to navigate the care based on your preferences as well. That being said, it can allow for opioids to be given in an emergency situation when that's medically necessary, and it doesn't hold any criminal liability to providers that do provide opioids to those that have an advanced directive saying that they wouldn't want those things. And there's no disciplinary action to those that fail to prescribe because they're concerned about having an opioid advance directive in place, or an inadvertent prescription of an opioid even when it's stated on their advance directive that they wouldn't want one. Some of the issues with this is that there's really no central database to maintain these documents. So there's a new piece of legislation that's out there, kind of recommends an approach to care, and it provides additional piece of paper that can get lost in amongst a lot of other records, and it can be revoked at any time by a patient advocate or guardian. So some of the other issues you may want to include, in talking about this, sometimes you can skip the treatment of pain with having an advance directive outlining no opioids, and so I think a lot of times the focus of avoiding addiction, avoiding the stigmas of opioids can thus make its way into the opioid advance directive, and it can then impact care. And so those are some of the issues I think that are present as a result of these things. And we'll see whether or not this will stand the test of time. I think Karen already talked about this non-malfeasance. We have a duty to treat pain. There is repercussions for failure to treat pain. So there's kind of a gold standard of you should our duty is to treat as providers. And failure to treat, there are some repercussions for that. I do some peer review cases, and a lot of time in the legal world, you refer to the standard of care and the meaning, what is reasonable for that patient at that time. And if the standard of care isn't followed, or you're challenging that standard, then if you're over or under treating, sometimes there's repercussions for those things, for that approach to care. I think this is something that we'll talk about a little bit further, and it may apply to the laws that we have in place, is intact decision making. If it's documented a patient is intact in their decision making, and they want to approach care focused on comfort. Maybe they sign into hospice, they agree, I want pain control, I'm okay with opioids, I want this approach to care. When the patient then becomes incapacitated because of the opioids or the progression of the disease itself, they may not be able to speak up for themselves. And at that point, who's speaking for them, and are they upholding those wishes? That autonomous decision that patient made to control their symptoms. And I think there's going to be some more examples we'll talk about at some point. So it's important to know where we're at practice-wise, where we are in the country. In Michigan, we don't have medical aid in dying, previously known as physician-assisted death or physician-assisted suicide, which was the very early terms. And it actually originated here in Michigan. Those who know of the famous or infamous, depending on how you look at it, Dr. Kevorkian. So it has made its way into practice and into law in many jurisdictions. Medical aid in dying is legal in California, Colorado, D.C., Hawaii, Montana, Oregon, Vermont, Washington, recently in Canada as well. And so this is something that may become a kind of more prominent in our practice landscape in the next few years to come when we're talking about laws. And I think it's just important to know that palliative sedation, treating patients' pain, sedating patients that are in the extremis of pain at the end of life, that is appropriate anywhere, and that is legal everywhere. And so I think it's just it's important to know that it's allowable by the laws in itself. There's a lot of resources that are out there that can provide some good references in regards to treatment of pain, suffering, especially at the end of life. And actually, this is a nice link. Originated the Jennifer Granholm era about the guidelines for use of controlled substances of treatment and pain. And this is for acute, chronic, and cancer-related pain. It really definitely it goes over the importance of a holistic approach to pain management. Number one, you have to assess the patient. You have to document what's happening. These are standards in amongst the care. Again, the standard of care is the importance, I think, whenever we're talking about legal issues. And so making sure there's documentation, that there's been an assessment, you know their history, that you've had a treatment plan discussed, you know the risks and benefits. And really that starts to streamline into the informed consent process. What are the treatments being offered? What are the alternatives to those treatments? What are the risks? What are the benefits? And making sure that the patient understands. And that plays into capacity. And any of the residents who have rounded with me, I think it's important to stress this with patients, with the residents, is making sure we're assessing capacity in everybody we come in contact with. Making sure that everyone's in agreement with the treatment. And especially making sure that we're taking into account those high-risk patients. If they're at risk for abuse or diversion, making sure that we're taking extra special precautions to make sure that we are not putting our patients and other society members at risk. And then making sure we're coming back to that plan on a regular basis. And then asking for help when we need it, asking those pain specialists and palliative providers when needed, and even when it's above and beyond that. Even sometimes we run into ethical issues in end-of-life care, even getting ethics involved. Just making sure that we're, key in keeping our medical records up to date. So I could go on and on. I could probably talk about a lot more, but I'll let Dr. Ryan go over some of the psychologic issues.
So John already brought up this concept of decisional capacity, and I'm not going to give a lecture about how to assess capacity today, other than to remind those in the room that individuals who are at highest risk usually have some sort of cognitive impairment or other potentially psychiatric illness, such as a delusional disorder, which could impair somebody's capacity to make informed decisions. In this case, I think it's reasonable that part of the formulation should have been to assess the patient's decisional capacity under the circumstances, as there's a progression of disease toward end of life, as well as then the interference potentially of polypharmacy or pharmacy in his ability to make decisions. What I did want to point out is research has shown over and over and over again, I think these are really key points for anybody in here who ever assesses for capacity or tries to consent somebody for a procedure or give a treatment recommendation. that by and large, providers tend to overestimate an individual's decisional capacity. And so we often, if somebody's pleasant and they smile and they nod their head, we believe that they understand and that they're able to follow through with your treatment recommendations. There's also a very poor correlation between results of a formal capacity assessment tool and what the provider or the relative say from their personal experience. Psychiatric illness does not necessarily correlate to lacking decisional capacity. So somebody with a schizoaffective disorder, for example, may have capacity provided, their mental health is under good control and, delusions are not interfering with their ability to make informed decisions. And, of course, that cognitive impairments in older age are certainly stronger predictors. So another issue that we wanted to talk about were about some of the family concerns. And certainly the case represents that there's clearly some family issues here. But there's a variety of ways at end of life, and particularly regarding opioids, is how families may interpret or have a view of how the opioids are used with the patient, that sometimes they maybe demand more of something, more treatment of some kind because of some perceived relief that may be given, or they might refuse certain interventions even though it would be within standard of care and exactly what is the ethical and humane thing to do for a patient. An example of this, and actually I make a statement in the next slide, is if the patient happen to be a prior addict that has an addiction history, whatever it may be, and they may want no medications that have any addiction potential at all for a patient, even though maybe they have very severe pain, and that's how we would treat that patient humanely. Additionally, and in this case, the son appeared to be interfering in care because of potentially his own addiction issues, personality concerns, whatever it happens to be. Part of this with the family issues is also about the communication that our teams have with patients and helping them set up realistic expectations for things like, in this case, with opioids for pain control. Some providers or some family members may want the patient completely knocked out so that they don't have to experience pain, any distress at all. And then in other circumstances, no, I want them to be very alert and engaged. And when we look at adequate pain control for some end-of-life issues, sometimes we sacrifice clarity and thinking for adequate pain control and vice versa. And so that can be a very difficult balance to strike in some cases, and it's something that we as providers need to mediate, but also then to be communicating with the family members and patients about the risk-benefit profile. Also then, because we're talking about end of life, is sort of normalizing the phases of dying and getting families and patients, for that matter, prepared for what they might see and how terminal illness may progress over time, so that there is some emotional processing of what may occur and reduce the risk of high reactivity at a later stage. And of course then normalizing their stress. The other issue that came up was this idea about dependence and addiction. And I'll be honest, I don't have a great opioid addiction tool to share with you today. There's this opioid risk tool, which I'll talk about in a second. Part of the communication piece with regard to the dependence and addiction fears is that families are worried that a patient who's never maybe had addiction history at all in their lifetime might suddenly at 98 years old develop an addiction problem. And so helping patients and families sort of overcome these issues, and while respecting a patient's wishes not to be just treated with medications that they really don't want to be having. So, and again, so some patients just say, knock me out altogether. I don't want to have to experience this. Just knock me out so I can die peacefully, which of course we know, as Karen pointed out, is not an ethical strategy. And then, how to treat those that do have an addiction history. So there is this opioid risk tool. This is an open source tool. There are other tools that exist, but many of them you have to purchase. And so I put this one up today. Essentially this gives a score, and this is open for anybody to use. It gives a score that shows whether or not there's a high risk for opioid abuse. So this is before the addiction behavior even happens. And if you look at the questions on this, so it's looking at the family history, the personal history, if there's any sort of history of sexual abuse, and then any other psychological disorders that may have existed. And then it's like a risk stratification. And so it doesn't necessarily mean that somebody's going to absolutely engage in addictive abuse behaviors. It just means that their risk is higher, and so it's maybe somebody that you have a more transparent conversation with, setting up appropriate expectations for care, and doing your own sort of self-check in your prescribing processes, so that you don't set a patient up for failure. To assess dependence or more addictive behaviors, there's a variety of things that we look at, and they include obtaining multiple prescriptions from different providers, preoccupation with certain medications. I'm sure we've all heard stories about people that walk in the ED and say, I need 16 milligrams of Dilaudid IV with Benadryl push now. That's the only thing that's going to treat my pain. Obviously, if there's any sort of buying medication on the street or obtaining it from friends, that should certainly raise alarms. Repeated dosing requests for escalation without any sort of necessary change to medical situation. Obviously, if somebody has bony mets and there's progression of disease, then we would expect that there would likely be an escalation for opioids over time. But with no change, you should be asking why. And then I always love, my son stole my medications, or I don't know what happened to them. They just disappeared. I swear they were all there. Other things that we should also consider is, end of life brings up a lot of existential issues and a lot of emotional issues that I'll get into in the next slide. And so this idea of chemical coping, and so it's this maladaptive pattern of dealing with emotional distress, which is considered a type of opioid use. And so instead of allowing the treatment with the opioids to persist, to work to address some of the emotional concerns that may exist. And if you can sort of treat some of the underlying issues, then the pain may get better. People who have uncontrolled anxiety, for example, tend to have exacerbated pain experiences. And so helping educate those individuals and give them additional coping resources for managing stress would help reduce then their requirements. And then there's, of course, this idea of pseudo-addiction, which is essentially, it presents very, very similar to the top list about how patients try to escalate in their prescriptions, or how they might try to obtain, or they become very preoccupied when the next dose of the pain medications come. When people have poorly controlled pain and they're underdosed, then we can see addictive or abuse behaviors occur because their pain is not well controlled. And so it's something to always be thoughtful of and use as part of your assessment with patients. And then, of course, some of the emotional factors, and I won't go into great detail about all of these things, but as you can imagine, end-of-life concerns related to anger and fear and regret, and the whole grieving process, feeling very alone, and that idea of despair. These are all issues that certainly come up for most people, and can also translate into how their pain is managed, and whether that be well managed or not.
So when you have end-of-life patients, it's pretty common for them to have some type of symptom. The common symptoms we do see: delirium, pain, agitation, dyspnea, anxiety, nausea, restlessness, vomiting. You can go the gamut with it. Primarily, people use opioids. The other thing is sometimes that we see is for patients who are a little bit more cognitively intact or awake, they talk about, for example, their loved ones. So we call it near-death awareness is what we see. So they sort of describe saying, this is what I think my death will be like, or I start seeing loved ones who have passed on, and this is what they worry. For us, I think the big thing that we worry is then everybody talks about is, what is a good death? Like, what does it mean? What is considered a good death? Because what could be a good death could might be, I'm okay with going on a ventilator, dialysis, feeding tube, totally okay. In the nursing home, that's totally fine with me. But somebody might be like, I would rather die at home with my family, be as cognizant of the fact and going on. So the kind of phrase that I found that I thought was very appropriate, and what kind of most people would consider or constitute a good death, is free from avoidable distress, suffering for both myself, family, caregivers in general, and it's consistent with both your and family's wishes, and with the resident sort of like clinical, cultural, and ethical standards that we as a society have to deal with. So the other big thing that kind of kind of interferes or can sort of cause a barrier is religion and culture with other patients. For example, Buddhists. When one of my colleagues, when I was a fellow, the head of my department was a Buddhist herself, and she always said that when her end of life came, she would prefer to have no opioids or minimize them as much as possible, because what she believed and what she was trained to believe for her religion and culture was that you need to feel the transition from one life to the next. And to me, I was like, I don't know how I feel about that, in all honesty, but that was her choice, and that was what she expressed. She always used to tell us, my own dead body could practice medicine. So, I took it with a little bit of humility in that sense. And each religion or cultural practice has their own things that they need to do. Some religions need to be there at bedside. They need to wash the body, actually, when the patient passes away or before. Some of them, they need to pray. Some of them, they feel that they can't be there when this happens, or they need to see certain things be done, or they want you to be there with them. And it is different cultural practices that each one has, and we have to be cognizant of that to some degree. Another thing that we talk about, and we sort of throw this around, is the idea of suffering. But who is the person suffering? Because if you see a patient, for example, on a trach, on a vent, they're trached and pegged, and they're minimally responsive, but they've been this way for X amount of time, and their family says they have good quality of life, and that's what they see as quality of life. But you might see that is terrible quality of life, because that's me. But my thought is kind of like, who am I to decide how you should live your life? I hope that before this happened, you and the family talked about what this might mean, and this kind of goes with your express wishes, because I don't want to do something. So the patient, we think, is sort of the primary motivator. Sometimes they're interactive with us, sometimes they're not. And it really depends. Sometimes they can't. Families are great and bad at both times. The problem is a lot of the times we're treating symptoms that are actually the family perceiving a symptom. And we should be well educated and well knowledgeable about what are the symptoms that we're seeing. And so I like to ask personally, do you see your family member in distress? Tell me what you're seeing, because it's not just about me, because what I might think is suffering might not be perceived to them. And I can easily give these person opioids or benzos or whatever to treat something that is really just my perception, not necessarily the patients or the family, if both of them are telling us. The other part is actually us in general, like what I perceive. Sometimes we feel like we failed. I couldn't have done more for this patient. The other thing is I've had patients over my very minimal 2 years, last actually, asking me for palliative sedation, or can you just end this for me? And I have to tell them, I'm sorry, we're not in a state that allows me to do that. Or I've also heard, oh, you're the team that's going to help me die. And it's how do you respond to those questions? Or, okay, hey, I'm waiting. When is this going to happen? When is my death happening? Can you shuffle me along? So communication is the big thing. So explaining what the dying process, not being afraid of what it means in all honesty, understanding what it means to be in transition, meaning one phase of life to the next. The other big thing is telling families what you should expect to see, hear, smell, because everybody is a little different to some degree, but the process itself is similar. And then once the patient passes away, what are the things that we do now? For example, if your patient is not from this country, do they want to be buried here in this country? Do they want to be buried? Do they want a coffin? Do they want a cremation? So it's all of those practices which helps to decide what would be the end of life care. Because should the end of life care be here in the States? Should it be in the hospital? Should it be at home? So the big thing we have been talking about is treatment. So what we primarily you will see us do, and you guys as well, is opioids. So there's many ways to give them, and I just threw out kind of the common ones. The common ones that we see is morphine, hydromorphone, fentanyl. People like it. It's easy to accept. The problem is right now, there is a shortage, which is fun for some and not for others, because these are people who are potentially suffering. There's end-of-life needs, so their time is very minimal, and I cannot give them the appropriate symptom control that they might require to relieve their suffering, whether it's my perception, family's perception, or their own perception of suffering. So the other thing we talk about is when we start medications for treatment of suffering, for comfort, who are we titrating the comfort to? Because I can say they look comfortable. Family's like, no, they're in distress. Patient says, I'm feeling distressed. And one of the things that my colleagues have talked about, you're using your opioids and other medications. The distress might not be physical distress, spiritual, emotional in that sense. So is it appropriate, or should we be using opioids to treat those non-pain symptoms? Again, our wonderful narcotics shortages. So the companies actually out there in the States aren't making as much opioids then. So I always constantly hear, oh, we can't get you IV Dilaudid in this form because we don't have enough of it here. But I might be able to give you this. So we kind of have to deal with it. Another big thing is that the CDC has actually started creating guidelines of saying they recommend patients to be on lower doses of morphine per day. And they're not yet deciding on whether it's end of life. So groups who are involved with patients at end of life, so for like ASCO, for the cancer patients, are pushing back and saying having patients on less than, for example, 90 milligrams of morphine per day is not feasible for these people. So we're creating a culture of opioid fear that you're not giving these people adequate pain control to manage these patients. So then the next one that we kind of discuss, and the case really talks about, is like when patients become end of life and they're dying, do I care that they might divert their meds, whether it's the patient themselves or a family member? In our case, that was the concern. To be fair, on hospice, you can still divert the meds, even if it's not the patient. The patients it might be a family member who is there. We try to do it as best as we can. It's a lot less common in the inpatient setting, whether it's in a nursing home or in the hospital. But like anything, people find a way. And like we said, it doesn't always have to be the patient who's the diversion. So you always should think about, and it's the big thing is sort of going back to the ethics that my wonderful colleague Karen brought up. How do we treat these patients but give them adequate pain control? And that's kind of it. So I'm going to open up the questions for everybody, and I will bring it back to Karen.
Oh, great. So that was a lot of information in 43 minutes, right? So like I always say, ethics for lunch is not meant to solve any of these ethical problems. So what we hope to do is to give you the tip of an iceberg to prompt your thinking for wanting further education about some of these ethical issues. So who has questions? Okay, done.
So especially considering the case in that very last slide that you presented, I'm interested in how monitoring compliance changes in this specific population. So if you do find that someone's diverting, what would you do differently in these cases?
Okay, so you're wanting to know regarding like the situation the case example that we gave, what would we do in real life regarding concerns about true diversion, and what are we bound by?
Oh, do you want me? Okay.
Come on, back up here, buddy.
Excuse me. So unfortunately, there aren't any guidelines. So a lot of it is anecdotal evidence and people's comfort. So a lot of it is, setting a family meeting, talking with the patient and family on like, what is our concern with this? And sometimes it actually becomes to the point of, first they're thinking about whether opiates are even appropriate. So sometimes they'll shorten the scripts. Instead of giving them a lot of scripts, they do actually shorten the supply. No opiates are kept in the house, for example. Most of the times when patients go home, they have a comfort kit, meaning an emergency stash of opioids and benzos and other medications they would use in an emergency. Sometimes the hospices will look at using short supplies, just you only get X amount of days and you go with it. Sometimes they actually have stopped using opiates and said, you're not, unfortunately, the patient. Or they'll even look at saying the patient cannot be no longer taken care of at home for whatever reason because we can't provide adequate relief to the patient in this setting. So let's either create what's called continuous care, and there's a nurse going there every day, or they said, let's look at getting to a nursing home, or let's look at bringing them to the hospital for safety and monitoring. There's not really great way to do one or the other, and a lot of it is the practitioner's comfort level to do it. And I have seen some people saying, I worry that I can't give you opioids, and sometimes it's come saying, we need to talk about whether you or this person can't be part of your care team. Did that answer your question?
Yeah.
There's
Okay.
another question over there, I thought. No?
Yeah, Kristen?
Repeat the question.
I guess I was just wondering about this idea of saying that being knocked out for a patient is unethical.
Oh, that's you.
But no, my understanding is that palliative sedation is widely accepted as ethically appropriate, and so at this for physical symptoms, so if you can't control any physical symptom, it is acceptable to essentially knock a patient.
Sure,
We wouldn't
sure.
use that term,
Yeah.
but to make them
Yeah. So you're just wanting,
that they're really not conscious,
Yeah.
so they can't experience the
right,
distress.
right, absolutely.
That's a whole separate.
No, no, no.
But it is something that I think, and there's actually debate in the literature whether palliative sedation is appropriate for existential distress. So it could be that situation that someone just wants to be
Correct.
sleepy because they're in a state where there isn't medical aid in dying, yet they don't want to.
Okay, so Dr. Cheston's question is about clarifying when we were saying that we were weighing and balancing the benefits of adequate pain control versus what some people would perceive as a harm of being completely knocked out. And that actually is ethically appropriate, and she's absolutely correct. Palliative sedation has been approved even by the U.S. Supreme Court as an appropriate treatment for intractable pain and distress at the end of life for the dying. But I think when you do that, you need to, one, have those discussions about, is this what this patient wants to have done? Is this how this patient would choose, right, to weigh and balance those concerns about being alert versus being in pain? But it has been ethically endorsed by the U.S. Supreme Court. So that's something that's looked on. And it is still debated in some cases. And it's not always, or the patients may be clear on their wishes. They may not have adequately expressed those to their families, and a lot of times they may have that distress as well. There's a question back there.
So my question was about partly about capacity assessment, especially when you're caring for a patient who has limited health literacy or a different theory of illness than the care team has. And so in those cases, I found it very difficult to differentiate between an inability to understand or articulate why the patient is being cared for and the risks and benefits of treatment, and differentiating that between the fact, that they don't think what we think is causing the illness is actually like a disagreement rather than a lack of ability to understand.
Okay.
Repeat the question.
Sure. Well, I'm going to clarify the question first. So you were asking, I think I got sort of 2 points out of this. So it was a question about assessing the capacity, and one about whether or not they actually truly comprehend, and maybe this interference of health literacy could be a component of that, versus that they have a differing belief system. Their values differ, and so and so how do you assess that, and then what do you do about it? So let me address the capacity issue. Somebody's ability to verbalize in some way, or communicate, I should say, because sometimes we even do capacity assessments when somebody is mute, only able to handwrite or use hand signals, is the establishing their capacities on the burden of the provider assessing the capacity. And it's a question of judgment. And as long as the patient can communicate in their own words what it is, even a basic understanding, then they would have the capacity to do that. As long as there's no interference and they truly seem to understand, even if it's very basic and not as complex in thought as you have, what their wishes are and what the treatment is, and the for and against the side effects of treatment, then they would have capacity. Now, if you have somebody that just has a different value system, I mean, you could take into consideration like somebody who's a Jehovah's Witness and they don't get blood products. That's widely enough known that we adhere to that, that we support that. Some people have religious beliefs or cultural beliefs that would not allow them to consent to certain procedures. So it's going to have to be taken on a case-by-case basis. And so getting some information about what it is that's feeding into their belief system and their value system, and establishing that at the outset when you know that they have the capacity to do that. Now, I say this with recognition that if somebody has a persecutory delusion disorder, and that's the FBI are going to come and take their mind if they get morphine IV, then that would be somebody that wouldn't have capacity. So I don't know. Did I answer your question?
Yeah, partly. I think so. I think in the situation where the patient has a different understanding of, so you say, well, you have serious liver disease, and that's why you're having these complications. No, I think that it is I think that it's the poisons that are in the environment that have been affected. I think it can be complicated to differentiate.
Yeah.
whether there's whether my patient is capable of
Right.
understanding, or do you just disagree with that?
Right. So, and this is where capacity assessments can get very complex sometimes, because it's a question of judgment and it's sort of on a sliding scale. The more complex the decision needs to be made, the more complex the patient's understanding needs to be of the decision. So if it's something that's relatively straightforward, they need to consent to have a blood draw, or they need to consent to a CT scan. As long as they can stand still or lay still, then everything will be fine. But a liver transplant is a totally different scenario, and so their understanding, their ability to follow through needs to be much more comprehensive. Yeah. So you'll run into that, but use your best judgment. Do no harm. Who else? Anybody else have a question yet?
I'm very concerned about the CDC position in terms of opioid limitations, especially for patients who are terminally ill. And I'm wondering, how are we at Henry Ford trying to address that and still address balance and comfort?
So the question is concern, I guess, foremost about the recommendations or statements from CDC about limiting opioids, and how is that going to affect practice, and what are we doing at Henry Ford to try to, I guess, make sure that we're still doing the right thing. I think really when it comes down to it, those are guidelines, those are recommendations. I think it's trying to answer some of the challenges in our nation with opioid misuse and overuse, and the repercussions of that sometimes are our sickest patients, the hospice patients, palliative patients that may not have thus as much access, or even non end of life patients that just need symptom control. And I think we just have to each provider that's out there needs to just keep into consideration that these are guidelines, these are recommendations. It isn't a mandate. And I think really when it comes down to it, we still have to keep the patient, each individual patient, in the center of the discussion. What is the best thing for you? I don't know if there's any specific programs that Henry Ford is doing at this point in regards to education. There's tons of educational programs that are going on out in the communities. I don't know if that answers your question enough, but I think it really comes down to, these discussions here, and we're educating our up and coming physicians, those that are out in the communities already, educating them about our responsibilities in care. Any other questions? Yes.
My father was up for a lung transplant, and then they decided he was not a candidate. So his prognosis was poor. So what I asked is that you and clarify why he was just on 2 liters of oxygen, not in full distress, but able to make decisions for himself, and discuss with his pulmonologist what the plans will be when the eventual deterioration comes. So then he was able to make decisions about, and then we could respect those decisions. Because at the end, people do, we did start him on narcotics at home, at my parents' home, and he becomes, they become uncommunicative, and it is like a loss. It's like, gosh, but he was suffering so much that loss of consciousness, or loss of interactability with the family wasn't worth him suffering, not being treated appropriately, or what I call appropriately.
Absolutely.
And so I am concerned.
Yeah.
He certainly was on narcotics at home, and for a while for comfort. And I do have the same concern about the state getting involved. And he was not going to get better. He was not going to recover. And this provided some comfort in the last month or so of his life.
Thank you for sharing that. I guess for those that are at the remote site, I'll kind of try to eloquently summarize what you've just shared with us. It's a really nice story. I'm sorry that you had to go through this process, but so one of the audience members shared about how a family member went through some issues with end-stage lung disease, not being a transplant candidate, and having open and upfront discussions at kind of the time of figuring out that no longer a transplant candidate. And then really just being upfront and open about making a plan of care and making sure that comfort is being included. And really nice to hear that he was being able to be at home with his family and had decent pain and symptom control there. And unfortunately did go through the progression of the disease process and lost his ability to communicate, which is a very big challenge when families have to go through. You lose that interaction, and I think it's very very much a natural process where we want to hold that relationship as long as we can. It's very natural to keep our standards. You want to keep that relationship, even though that there is it's the right thing to do for the patient to be comfortable and to pass. But yeah, so there is concerns about these things that are developing at the state level. Can it be impacting our practice? And it certainly, I think it's starting to over the last few years, it's actually been a challenge with practice, especially in palliative and hospice care. But I think again, it comes down to having those discussions up front and making sure that families and patients are educated about the expectations, what are the goals, and what are the implications of treatment. So
maybe one more question, if there's one more question out there. If not, I'd like you to join me in thanking our panel, Dr. Rose, Dr. Bolek, Dr. Ryan. Thank you so much. I hope you enjoyed Ethics for Lunch, and I hope you come back in June.